But let's start first by just defining what trauma and PTSD are, because this is something where people sometimes throw the word trauma around a lot. And it's not to say that anyone has like the monopoly on how do you define trauma. It certainly can be subjective, but there, from a standpoint of diagnosis in a clinical sense, certainly from like a forensic sense, from like a lawsuit side of things, it's actually important that we know what it is and what it's not and what it can be. But it can take a bunch of different forms, and we'll get to the criteria in just a second. Although we don't want to get too bogged down in there. But it can come from car accidents, from the death of a child, abuse at any age, but certainly childhood is a big one. Adverse childhood events. I think I partnered with eCare to do a presentation about that a month or two back. Combat related, certainly for veterans, sexual related traumas, losing a limb for any reason, being mugged or assaulted on the street, witnessing a murder, fighting a really aggressive illness and making it out the other side. I mean, it could go on and on and on and on and on. But at the end of the day, regardless of whatever we think clinically about it, the most important part about working with someone with a trauma is that we respect and validate how someone perceives their past. Sometimes it's easy to either get a little bit rigid about these things, or wonder like, can this apply? Should this apply? Ultimately, I think a lot of our treatment really should be symptom driven, and what it seems to look like what is someone struggling with, and then based on that we try to pick an intervention that matches what they're going through to try to get them the outcome that they want. And certainly there's transdiagnostic skills and things that you can do that forming rapport, active listening, kind of like humanistic sort of Rogerian stuff. But then there's also sometimes these more specialized interventions and techniques and approaches, which is really, again, what we're going to be drilling down on a bit more today. So PTSD, though, does have a specific definition, and we, of course, diagnoses. There's been we talk a lot at like this philosophical conceptual level about like, should we be using diagnoses and labels? Should we view things as more of being on a continuum? I think it depends on ultimately what you're trying to achieve. But what I will say is that if someone is dealing with a cluster of symptoms that looks like post-traumatic stress disorder, it can be helpful sometimes for them to have that label so that they know what they're dealing with, and also in some ways to give them a comfort that we actually have a lot of good, highly researched treatments that show really solid efficacy. Actually, all three of the cognitive behavioral treatments that we're going to talk about today, at least an overview. Again, CPT, or cognitive processing therapy, is going to be where we do the deep dive, but all of them actually have about an 80 to 85% success rate at achieving remission of symptoms if they're delivered by someone who's been trained and knows how to do it. So there's really a lot of good treatments for this out there, and I think to that end it can actually be helpful for someone to really wrap their arms around what they're dealing with. But the first criterion A, for having PTSD is that you've had exposure to a traumatic experience. And the definition of exposure has changed a bit over the years. Originally, it was more, you have to like experience it. You have to be the one who's being aggressed against, or who's been hurt, who was hurt. But we actually know now that it does not have to be limited to that. It can be something that you witnessed. You can see something really grisly or terrifying happening to somebody else. You could also learn about something happening to someone you care about. Sometimes just hearing it secondhand can create this reaction. It's also possible to get PTSD from a really aversive circumstance that is that you didn't go through it, but you're seeing it secondhand. So like, for example, first responders who like walk in and see dead bodies, or the cleanup crew who picks those things up, that's very difficult to see and to witness. Even if you weren't the one where it happened to, you're still seeing human remains and picking it up, that sort of thing. So it's very possible to get PTSD from that as well. But that's the core, right? There has to be that initial traumatic stressor that sets the rest of this into motion. The second criterion are intrusive type symptoms. And intrusive symptoms, and again, I'm not just going to dive too deep. We all should have a copy of the DSM, so I won't spend too long on just listing it all out for us here. But intrusive symptoms basically are when the memory of the event intrudes into the present. So this could be a flashback where it's just like intrusive thoughts. It could be a full-on immersive, almost dissociative flashback where you really feel like you're there again. Intrusive symptoms can be nightmares, which are fairly common, and more on that in a minute or two, but traumatic PTSD type nightmares, as well as then almost like a physiological intrusion where your body feels like it's going through it again. The third criterion C, is persistent avoidance of triggering stimuli. So avoidance is a huge part of how all anxiety and stress disorders persist. And again, we're going to talk more about that shortly. But basically, if you have PTSD, you are trying your best to avoid external reminders of what happened. So that could be places that are associated with it, people, maybe people with the same name, smells, anything on the outside that reminds you of what happened can create this adrenaline response essentially, and you really don't like that feeling, so you try to avoid it. But you also oftentimes try to avoid internal stimuli, which means essentially thinking, and that's part of why substance use disorders and addictions go right along with trauma, because if you're drunk or high, you're probably not thinking about what happened, or it's a means of escape. You also commonly will see these folks who are dealing with trauma just keep really, really busy, not necessarily give themselves time to really stop, think, sit with themselves, because when they do, the thoughts arise, and that's really unpleasant. The next criterion is a negative alteration in cognitions or mood. So this has to do with a lot of hopelessness, feeling different from everybody else. It can involve sleep difficulties, feeling depressed, just really like a depression that sticks around. A lot of times when you see like co-occurring conditions, psychiatric ones like anxiety, generalized anxiety or depressive symptoms in someone who's dealing with post-traumatic stress disorder, it's usually worthwhile to do some sort of evidence-based PTSD treatment with them first. See if you can get those symptoms to die off a bit, to calm down, and see what's left over. You might actually find that the PTSD is kind of like the linchpin that holds everything else together. And if you can take that out of the equation, so much of the other things start to fall away. Including those in the next category, which is basically hyperarousal. So you've got these alterations in arousal or reactivity. So these are things like a really enhanced startle reflex. So if someone came up and tapped you on the shoulder, you'd really jump or have an intense reaction where you'd swing around. You're hypervigilant. You're always looking out for danger. You have a difficulty concentrating, can be a big one usually because you're being disturbed by feelings like you're not safe. Anger is another big one in that category as well. Then those are really the 5 things that we're looking at. You've got the exposure and then those 4 clusters of symptoms. It should last more than 1 month. Less than 1 month is acute stress disorder, and we'll talk more about that in a second. And then it causes significant impairment in your life and is not substance induced in its entirety. And that's how we define PTSD. And we'll talk more about assessing it in a second, but that's generally like when I'm assessing somebody, or if I'm doing an intake and someone says they've been through something, usually what I'm asking about I'm just kind of taking up some broad strokes over those 4 big if someone's experienced the traumatic event, I'm going over those 4 categories and really asking, like, are you having these sorts of things? I'll often use the word like the way I'll introduce the question is I'll ask if they've ever been through something that was very traumatic, or if they witnessed it happened to somebody else that almost still haunts them right now. When they're reminded of it, it really shakes them up. It's on their mind a lot. And usually that question at the front end, like that's enough. Like if people have this going on, they'll respond properly to that. And even some who aren't really being haunted by it anymore, or doesn't really define their actions day to day, they'll still sometimes, they'll throw out the traumatic event and they'll talk about it, but they won't have these symptoms. So it might not necessarily then need to be, even though they went through a trauma, and it's still helpful then to have that, in our awareness about how we treat this client, to not necessarily have that be the center of treatment.